Hello and welcome to the NK Active podcast. This is a special episode because today it is World Arthritis Day, and we are very, very excited to have an extremely special guest with us, Professor Catherine Bowen. So, Catherine or Cathy?
Everyone knows me as Cathy.
Okay.
You might read my work as Catherine.
What do you prefer?
Cathy.
So, Cathy, sort of instead of, because you've got a very impressive CV and history, instead of me just reading off a bit of paper, sort of tell us a bit about your journey and everything and how you got to where you are now.
I've been a podiatrist for about 30 years now, but if I fast forward a little bit, it was when I was working in the National Health Service, and I specialised in rheumatology, and this was in Bexley Heath in Erith. And it was just a really great time working multi-professionally with rheumatologist, consultant, rheumatology nurse, the orthotist, physiotherapy. And we had such a great team for patients going. And that's really how I got involved in rheumatology. My focus then was on rheumatoid arthritis, which is an inflammatory arthritis. So it's very different to osteoarthritis because it's a systemic inflammatory disease of the joints. And it was only later that I got involved in osteoarthritis, that realization that the other diseases were managed by biologic drugs and they were becoming less disabling because of the drug management. But osteoarthritis has sort of got left behind in all of that. And we started to re-look at people who have osteoarthritis and how that affects their foot and their ankle, how that affects their gait. And when I moved to Southampton and got involved in research, I then met Professor Nigel Arden, who is at Oxford University. He was my PhD supervisor. And he is a world expert in osteoarthritis, particularly of the knee. So we translated all of that work and knowledge that he has to the foot and ankle. And there he'd taken over a major research study which was looking at women in London, in Chingford. So he has this cohort that has been investigated for nearly 25 years now. So the ladies were all recruited back in 1987. And I was able to join that study for the final year. So we brought them all back 25 years on, and we took foot x-rays, we took lots of data about their feet, about the way they walk, all their characteristics. And that's where we really got to understand how much osteoarthritis does affect people, but also how much they can do to manage it as well, and how much we can do to manage it.
So do we think then, because with rheumatoid arthritis, there's a very sort of medical managed approach with it, with drugs, and we possibly almost know more about the disease process itself. But do you still think there's a bit of a culture of, do you know what, you've just got a touch of osteoarthritis, don't worry, just get on with your life type thing. But actually, I can't remember the stats off the top of my head, but you may know, but the amount of people osteoarthritis affects in the UK and then worldwide is absolutely huge. And then when you ask people about how it affects their daily activities and their sports and their exercise, and you're like, this is almost like this silent cohort of people, but actually it's not a small number, it's an absolutely massive number, where actually we're maybe missing a trick on how we can help these people, because you said that there are lots of myths out there around about arthritis and osteoarthritis in particular, about what it is, what you can and can't do. And I think a lot of the time, some people feel like they're just sort of brushed under the carpet, as it were.
And you're so right about that. So often people have come to us, and there are so many myths. They're told, oh, it's just arthritis, the pain in your feet, the pain in your ankles. It's just arthritis. There's nothing we can do about it. But what is just arthritis? There is damage to the joints, and it is a mechanical damage. But if you manage and strengthen the muscles, the ligaments, all the soft tissues around those joints, you can manage the deterioration in the joint. So we know that now. Yep. And the reason we know that is over the past sort of 10, 20 years, we've been developing imaging techniques. So people would have had x-rays previously, but when you have an x-ray, the damage is done. Mm-hmm. Whereas a lot of our work here at Southampton, we've been using something called ultrasound imaging.
Yeah.
You know, what you look at babies with, you scan babies. So we've been using that on the feet to look at the joints in the feet as well. And we can see the damage starting in a joint before the bone really becomes damaged with arthritis. And we know now that we can encourage people to exercise, to do things to strengthen those foot joints that will maybe stop the deterioration in the joint quite so quickly.
Because was it Leeds, I think, or up north somewhere, they were doing some work looking at MRI scans as well, I believe, in almost before that joint damage happened on it. You could see what was going to happen on an MRI before. And do we actually know, if you see those early changes on ultrasound or MRI, and you apply the right treatment modality for that patient, do we think, or do we know that actually could we slow down the disease process of osteoarthritis, or is that something that we still need to answer?
In the research world, we haven't provided the data or the statistics yet to confirm that. But in the clinical world, intuitively, we've got reports from patients that can, it's not even just slow down, that you can arrest that disease by looking at the mechanics and the way that somebody walks. Because usually the joint is damaged because it's not, I call it parallel. So a joint has to be in a certain position to work well. And if it's slightly tilted to one side or tilted to another side, or it's pulled in the wrong direction, and that could be anything from the way you walk, it could be your knee or your hip that maybe changes the direction of your foot or an ankle. But if it slightly changes, you will damage that side of the joint more. So if we can tweak those then for a patient, and we can help people understand how to do that themselves, then they can probably stop that joint getting damaged, if that makes sense.
Well, there was some work further up looking at the knee, wasn't there, when people who had arthritis of the inside compartment of their knee, and then you stick a wedge on the outside of the foot, actually offloaded the inside. So we know that we can do that, but I suppose the other side of it is then sometimes what you see on the scan doesn't always then correlate with symptoms. And I've seen patients who have got bone-on-bone osteoarthritis but just got back from running a marathon, and I'm like, I'm not really bothered what your scans do, because you can run a marathon, you can do everything you want. And then you see some people who have very early onset osteoarthritis on imaging, but their symptoms are much greater. And that's, I should imagine, the fun of them looking at it from a clinician's viewpoint is then you then get to see actually, when all this stuff's done in the research world, how does that then implement in daily life? So I think Charlie was going to then start asking around about research groups or something, I think.
Yeah, so we have lots of access to charities and research groups that are looking at people with osteoarthritis. So we have our Versus Arthritis, and we work really closely with them, and we take on internships as well as researchers that are looking into that area. And I guess you know a few more as well, sitting on that kind of global scale of osteoarthritis. So talk to us what's been going on more globally.
I've pulled together a group of everybody that I know that's been working in research in foot and ankle osteoarthritis, and that includes people from Australia, New Zealand, America, across Europe. We have probably a group of about 60 world leading experts at the moment that we got together in 2019 in Toronto. It's quite a good conference.
Sounds amazing.
But the work that we've done since then is really getting all those great minds together to think, well, how can we move this field forward? Because unless we produce the data, people won't believe that it's, really it is worth doing this process, or they won't invest in further work or invest in the treatment. So we've just at this moment done an exercise between all of us where we've synthesized and pulled together all the research across the world that we know, and we're rating it and ranking it to set priorities. So within the next month or so, I'm hoping that document will be ready to be published. This is supported by our Centre for Sport, Exercise and Osteoarthritis, Versus Arthritis, which is a UK Centre of Excellence. Again, it's multi-professional. So it's not just podiatrists, it's medics, it's rheumatologists, sports scientists, physiotherapists. It's also endorsed by ORSI, which is an international organisation. It's an osteoarthritis research society. So again, they're based in America, but they're supporting this work. So although, you know, there's a lot of local groups as well that all feed into this, we've taken it onto the global stage with, you know, the notion that, you know, more brains are better than one, aren't they, to solve the problem?
Absolutely. And I guess those recommendations also feed into kind of guiding where further research needs to be. So then those early career researchers can then kind of work with those great minds to then keep building upon that work. So you create a wonderful network of actually answering those key questions that are for patients. It sounds fabulous.
So then we're leading it then back to, so we've got these groups available, and then are the aims of these groups to help then educate patients, educate clinicians? What are the plans to then try and disseminate that what's found on a research level and then implement that on daily life? Because sometimes what happens in the research world then doesn't match what happens in real life, because the joys of research, you can set the parameters quite nicely. In normal clinical life, that doesn't happen. So
I think that is so important. I mean, what is the point of doing research if it doesn't get to patients? So we need clinicians on board, we need patients on board. So all of our work will involve stakeholders, but the core group are leading researchers and clinicians in the field. It's people like Charlie who has a joint post, so being clinical academic, clinical researchers, where we've brought on more people and trained more people in clinical practice to do research as well. So do you want to say a little bit more?
I guess what you then think about is taking those great minds and thinking, right, how can I really apply this to the patients that I see day to day here in clinic? And I guess that's the bit that drives me is, right, what evidence are we doing, and how can I robustly measure to check that what they're saying actually works for the population that we serve? And that's the really lovely bit that we get to do. So there'll be lots of different ways of doing that. It might be that we'll ask patients to kind of join in on our conversations that we're having and see, is it appropriate? Should we be doing that thing or intervening that way? Or is that something that you're not interested in? There will be little bits with clinicians. So thinking about your different health services. So the NHS will operate slightly differently to maybe a private practice. So it's taking those different approaches and trying to implement them in different ways. So hopefully we'll come up with this wonderful network of strategies that work for patients and supporting patients to improve. There'll be that little strategy on how to support clinicians, no matter what their kind of profession is, so that multidisciplinary approach, but then also thinking about guidance. So how can we support those that are learning about osteoarthritis to make good decisions for their patients? And that comes through policy and guidelines. So we kind of have to attack it in 3 different directions to kind of have the global benefit of one.
So then going back, Charlie, your dual role. So here NK Active as a clinician, but then also in the university as a researcher. And I think all 3 of us agree that actually in implementing in clinical practice is where the research needs to end up, because then you then have the effects on the patient, and that's when the patient then get access to the latest treatments and guidelines and evidence. So sort of, I know this is mainly aimed at people suffering with osteoarthritis and patients, but there also will be clinicians listening. So how can clinicians then sort of then try and help? Then what can they do to start trying implementing that research in practice, and then also start thinking about, okay, how can they then add to the research field, as it were?
Oh, a good question. So I think we have to tackle it in several ways.
I didn't even plan that. That's not even on the script.
So I think there's 2 ways of doing it. I think there's that using your core skill set to go and read the evidence, to look at those guidelines and policies and see where they fit within your own practice. If you're then starting to think, oh, actually, how does that work? Go and see models of care where they're using it, where you can see it happening. Go and shadow and learn from those experts in that field who are working in that area, so that you can start to build your confidence in using those skills. And then I also think it's about being honest with patients. If you're learning to do something new, then working with them through that to then embed that new thing into your practice.
Yeah, and I think then the other part is then looking at auditing then what you then do in
Absolutely.
because that's something I know we harp on a lot about it, but I think it is so important, because if we talk about osteoarthritis as an example, if we look at some of the work that I think it was Leeds when they looked at midfoot osteoarthritis, and they looked at the relationship between treatments of a stiff sole shoe, sticking a carbon rocker in the shoe, and then looking at muscle strength. And what was lovely about that paper was they all found that in that study, everyone who had midfoot arthritis had a reduction in strength through the inside of the ankle. Well, in clinic here, we've got tools to test that, and every patient we see with midfoot osteoarthritis, without fail, has a reduction in strength through there. And then we then look at our outcomes. When you then go back to then increasing the strength up, we then see that people's symptoms improve. Okay, we can't do anything to reverse that disease process, but we can help educate people on how to learn to manage it, so actually they take control of the arthritis rather than the arthritis taking control of them. Because I do think we need a bit of a culture and a mindset shift in around about that actually having osteoarthritis is okay. It's not all doom and gloom. You can still do a lot of things. We just got to teach you strategies on how to manage it and set you up with different things on how you can get by, because it's not going to go away. And gone are the days of where you're told you had osteoarthritis, so you got to rest and you can't do anything, because we actually now know that's most probably worse than doing too much, because you just decondition. Gone are the days. But actually, going off topic slightly, when we were looking about topics to speak about in our Arthritis Awareness Month, people are still searching on Google. I think it's the third most common search when you look at arthritis is actually, does clicking my knuckles, so does clicking joints give me arthritis? And we know that that's a bit of a myth.
Yeah.
But there is still a lot of work to be done with regards to that. So thinking then about the future, where do we think, so two-part question, where does the research need to go? And then B, also, how can we try and make research more relevant for people on sort of the front line, as it were, so you can get that impact to patients quicker? Because I think it's on average about 17 years or something from when a paper gets published. It takes 17 years to disseminate all the way down. And I'm sat there thinking, in the world of social media and whatnot, where it's just like, why is it taking 17 years? What barriers are in the way that need to come down? What restrictions are there? Where does the future lie? So that sort of ended up into a three-part question.
Yeah. Okay, where can research go from here? Very much more on understanding what's going on in the joints. So looking and defining the arthritis in the joint to start with, which means our imaging has got better. So even in the last 20 years, we can do that now. So we can get a more specific diagnosis, but then we've got all sorts of other tests and diagnostic tests that we know. Like you said already, you can test the muscle strength around the joints and see which ones need to be improved and for rehabilitation. So again, all of that is really positive for the future. The biggest thing that we haven't mentioned is BMIs as well. So there's a lot that goes around that, which is, part of the whole team approach to somebody. We know for sure a high BMI creates foot pain. There's a real direct correlation, foot and ankle pain, and is associated with foot osteoarthritis. That was one of the first papers that we published. And also, again, the work you mentioned at Leeds, again, they've already agreed with that. So all the work they've done, we know that. So there's a lot of things that we can do to support people and give them really good routines to do for their behaviour change as well, to help them manage it. So I think it's good, dispel the myths.
Yeah.
Motion is lotion is our key term, is what we say, and don't be afraid of the pain sensation, and unless it's completely seized up the joint. So that's sort of where is research going. It's going down that route in terms of knowing what it is exactly we're looking at. Possibly, I look at Charlie now in terms of how to get to clinicians. We have a lot more implementation pathways, and what I mean by that is people like me who are doing the research in the labs. There's money and there's investment for us to connect with clinicians like Charlie here and yourself, Nick, to make sure that what we're doing gets to patients much quicker. And I know the National Institute for Health Research, again, they're really keen. So anything that they fund now has to have a 5-year implementation pathway.
Okay, so that's good. So then that really helps. They're saying if we're going to fund anything, it has to be impactful within 5 years.
Yes.
So you've already taken a good 12 years off that straight away.
Yeah.
It's also us taking ownership, isn't it? I think that's the lovely bit, that I get to see the two blended worlds. And actually part of my responsibility is being able to blend the two, to be creative, to find those wonderful loopholes where I can demonstrate and disseminate in a different way. So the traditional way of it being published, that's part of it. But there's also other bits that you can do, holding festivals, having events, doing training programs. There's so much more out there that's attainable to us because of the technology and just the way the world's changed. So we just got to capitalize on it, enjoy it, and be creative.
So one other question I want to ask you about BMI. So with BMI, do we think we're asking the right question with BMI? So if we know in general the best way for a body to absorb load is lean muscle mass, so we know effectively the stronger you are, the better the body absorbs, tolerates load. Is BMI the right way to measure it in a way? Because you could get a athlete who is technically may have a high BMI because they've got more muscle than fat, and obviously muscle is much denser than fat. Do we know, is it purely BMI related or is it weight? So actually, even if you are, say, a England rugby player and you weigh 20 stone, but you're just 20 stone of muscle, does that put you at increased risk as much as, say, someone who is 20 stone due to lifestyle choices, shall we say?
Yeah.
Do we know that, or is, because BMI is still used in the medical world a lot, and I personally, rightly or wrongly, I think that's the wrong question, but I get why it's used because it is a very simple tool, and we haven't really got an answer of, well, we're saying don't use the BMI, but there's no one come up with a solution of use this instead. It's a case of don't use this, but there's nothing else to use. So
that's a really good point, because on the one hand you want really good muscle mass for the joints, don't you? So that's it. We're talking about a different population of those. So anybody who is reading the research, or clinicians reading the research, you look at the population where that research has been investigated. So our ladies, so we investigated 1,000 ladies over 25 years. They were recruited at age 45 to 65. To my knowledge, there weren't any elite athletes in that group, but I could be wrong whether we asked that question, but they'd be outliers within that. So again, it's about asking those questions, really. And when you are reading papers or you're reading things that are published, just go that extra bit and look at the population they're talking about.
And I think that's the key point, is that a lot of the time we can get hung up in the research, but then when you look at the research, it's good research, but it's maybe not relevant to the population that you see in. And in an ideal world, you would have some research that had enough participants in there that actually there were no exclusion criteria, because you had enough to then rule out any anomalies. But that's pipe dream kind of stuff, because that's where you need tens of thousands of people in studies and
absolutely. But that is where our global group comes in. So again, that does bring that back in, because we can do that. So if all of us have 2,000 people in our population studies and we collect the same data, then we can start to look across the board, and we can do diverse data as well, because again, a lot of the work in the past sort of, probably if you go back 20, 30 years ago, it's not on diverse populations.
Yes.
You look, there's no ethnic populations within there as well, and we know we need to improve on that too.
And this is where I think clinicians can really help, because if we standardize a set of questions that need to be asked, imagine you had every clinic in the country. I don't know how many healthcare professional clinics there are in the country, but there must be at least 20, 30,000 at least. And imagine if in each one of those, even if they contributed just 10 bits of data a year, then you can see how it can just snowball, and you can then start getting a really clear picture of the demographic. Because I'm aware here that the patients will see at NK Active will fit a certain demographic compared to different parts of the UK, and there's nothing we can do about that. That's just, but then it's actually the treatment processes we apply here may or may not work if you then take it out to a different type of population of patient. We just don't know. So if we start trying to bring things to an end, because obviously I appreciate you started off your career as a clinician, and now you've now morphed more into the research world. With sort of the latest research, knowing what we know currently, and obviously understanding that actually by the time this podcast is released, that could change, because that's just the world we live in with research. What would be sort of a couple of tips for people suffering with osteoarthritis and sort of helping them to sort of manage and continue their daily activities?
Do you want to?
Yeah, so for me, there's lots of things that can be done, but it doesn't necessarily mean that each one will be right for you. So it's putting it into the context of you and being brave to give things a go, and know that sometimes some stuff will work and sometimes some stuff won't. But it's finding that magic recipe, I guess, that works for you.
Yeah, and it's almost like we speak a lot in clinic that we're not cakes. We're all different recipes, so you can't apply the same treatment to every single person. And this is why you see a lot on social media, a lot of support groups, and I've got no issue, and I think they're really helpful. Some of the issues with those support groups, though, is when people say what's going to work for me, and what works for your friend may not be the correct thing for you. And that's, I think, where seeing your healthcare professional, whether that doesn't really matter what profession they are, as long as they have an understanding what osteoarthritis is, then they can then put together a suitable treatment plan that's going to be best for you. Because even us here, every person who has osteoarthritis that comes to us will go on a slightly different journey. If we tried to send everyone on the exact same journey, we wouldn't get the results that we do. But I think that's our ability here to take what's there in the research world, use our own clinical data, put the two together and say, we think this is going to be the right treatment journey and package for you.
Yeah, and that's why we say for patients, it's seeing the right clinician at the right time. So you can follow guidance. There's things up there about what to do. But what the clinician will do for patients is they will take and ask all that information and pull that information together to come up with a more tailored treatment plan for that particular individual person, which is really important in this.
So I think the one takeaway for me from this is knowing that we can possibly start seeing signs of osteoarthritis on different types of imaging apart from X-ray earlier. And we're not suggesting everyone who suspects they have arthritis go and request for an ultrasound scan, but what I did take away from that is actually, if you have osteoarthritis, trying to get on top of managing it early and trying to get the right network and support into you sooner rather than later. So it's almost trying to take a more preventative approach to it. So almost like prevention's better than cure.
Yeah. What I didn't say with the imaging really is that while we've been doing those studies, we also know that the clinical diagnosis matches. So we know that you can go off clinical symptoms and be and that's quite sensitive, and the management pathway will be similar. So it's very rare that you could go for X-ray and it would be different. But you're managing the pain, so the clinician will know how to manage the pain that goes with it.
And that's why in clinic, actually, for osteoarthritis, our imaging request rates are very low, because you can, off your history of your examination. And then I always say to a patient, well, we can get an x-ray, we can get an MRI of this joint. What's it going to change? Is it going to change the management plan for this? Unless we're planning to send you for surgery, which is a last resort, then actually we don't really need the image, because it's not going to change what we are going to do fundamentally. Do you have anything else you want to add at all?
Anything from you?
No, I don't think so.
No.
Just thank you so much for coming and being here today.
Thank you for inviting me.
No. Really, thank you for taking time out of your hectic diary to come and chat to us. So if you have any comments, please just post them below. Please do subscribe to the podcast, and we shall see you on the next episodes. See you later. Bye.